think he's a brilliant guy, but really socially inept.
Oh, God.
And I think, and he told me that, you know, the feedback that he got all through medical school is that you got to work on your people skills. So, yeah.
Oh my.
Yeah. It's a bit much.
Yeah. And then when you throw in these other factors, it's a lot to work on.
Right.
It's a lot to handle.
Yeah.
On any count.
But he's
Wow.
motivated. That's the positive. His motivation is very clear. And I think he would if I sent him to an occupational therapist for some of those things. I think he would.
Yeah, because if it could make him better in his job.
Absolutely.
And
Yeah.
his life.
Yeah.
Wow. Oh my
Yeah.
God, it's so interesting.
Yeah.
I just
Yeah.
I love to work in this area. It's so interesting to me. It's so different than if you don't have those problems.
That's right.
I've spent so many years trying to get in the head of someone who does that.
Right.
I can't understand because I'm not there, but I feel like I've gotten much closer than many have to understanding with all the work I've tried to do. So it's so interesting.
Yeah.
Wow.
Well, I know that you start in late May or early June. I can't remember. Robin told me the dates.
June 3rd.
June 3rd. So it's after Labor.
And I'll be here at the
Memorial Day.
Armory and at the Recovery Center.
Oh, good.
Two locations. So.
Good. I used to run the Recovery Center, so I know it really well.
Oh, cool.
And you have, talk about, it's an interesting couple of places because they're so very, very different.
Yeah, I don't know. Only what I've read online. Much about the Recovery Center.
Yeah.
But they all sound fascinating
No, I
to me.
think
So I was just so excited. I was like, in the interview, I'm
it'd be
like,
interesting
everything sounds great.
to run it to, if you are able to do something with the detoxes.
Yeah.
Because, you can really do some good stuff there around sensory motor integration.
Oh.
Because people, when they're using substances, everything is out of whack. And
Yep. Everything's out of whack as they're withdrawing.
Right, and early recovery, sensory motor integration is really key to getting the ball moving again.
Wow. It's nice that they do that, though. Even my brother, he only detoxed once in a facility. He always did it on his own, but in Bergen Regional, the only Medicaid facility in New Jersey, and they didn't, according to him, they didn't do anything. Just like stuck him in a bed for 7 days and he went to meetings. I'm not sure how.
That's tragic.
This is a one-sided story, but I kind of imagine that's a good point.
I actually think that that's probably
truth.
not uncommon. I'm actually very, very critical of rehabs because I think that they often miss the point.
Yeah.
And
here's your chance to change.
To really
change everything that comes after, so
exactly.
they don't.
And to sit in group talking about feelings day after day after day is such a waste of time.
Yeah.
Because that's not what people need in early recovery. They really need skills.
Yes.
And so I had a guy last fall who went to a country club rehab up in Connecticut, and it was good for me in a lot of ways, but again, it did not address things like refusal skills or
like actual
major.
What do you tell your family? What do you tell your friends? What happens when you go out in the public and this happens and this is around?
How do you say no?
Yeah, how do you go to the dinner at the dinner with the friends and refuse the drink?
Right.
How do you do this? No one teaches you how to do
No one
it.
teaches you how to do that.
Yeah.
Right.
That was like the hardest, that was not the hardest thing for my brother, but that was an ongoing thread.
Absolutely.
I've probably been out going, 30 years probably going. And,
hi, Emily.
good to see you.
How wonderful to see you. How's retirement?
It's good.
Yeah, I bet.
Grandparenting is really great.
Yeah.
Are you actually off this semester? Or are you
I
still
am.
doing stuff? Okay.
I'm doing a research project, but in all the site visits. And who did I bump into? Someone but Edinburgh home. She said to say hello.
Okay.
Yeah.
Thank you.
Yeah.
Yeah.
It's so special.
Indeed.
Okay, it's not good.
Yeah.
That's so interesting. I can't wait. I'm right now a voluntary inpatient unit at a psych ward at St. Patterson's, and there's a lot of detoxing skills going on. They have a good structure.
Medication management and stuff.
Yeah. And the OTs are super hands-on with skills training. And it's nice to have a good model to start with and to bring in to see that it can be done.
Absolutely, it can be done, and it can be done well.
Yeah.
Yeah.
That's awesome. That's so
And
good.
the guys really like it. That's the thing, because they learn something that's very immediately useful to them. It's concrete.
Yeah.
It's,
They all perk up, which is so interesting.
Yeah,
My
it's
brother's
amazing.
Mr. I Know Everything, so
Yeah.
he was so against it. I wonder if he had it, if it would have saved years. Like,
it might have.
yeah, because he was Mr. Successful, you know, Wall Street banker. Like, I know everything. You don't need to.
Well, I just remember the first year that we did this, one of the most intransigent clients that we had at that particular time, that was the thing that changed his life. And he talks about it to this day.
Oh my God, so exciting. It's good to see you again, too.
Yeah, how are things going?
It's crazy, you know, doing 500,000.
She's been telling me, yeah.
So in my main job, I run a program, actually in narrative medicine, 110 students. I'm the only person working on this program. I also help with all the events. And yeah, but I'm going on project renewal fieldwork this summer, which
Isn't that
is super,
exciting?
super exciting. So we're talking.
Do you
Yeah.
know what's that yet? Or?
Yeah, I got the Armory because I fought to be with Leanne. So I got the Armory and the Recovery
And
Center.
she's going to be at the recovery center.
Yeah. Leanne was my
So she
student
can
back in
do-
the day, so I
she
knew
can do
Leanne for years.
detox, and she can do outpatient.
Yeah, which is because of my
that's
experience with
really-
my brother is like super, super, super exciting. I think I've really pushed that in the interview. I wanted to be at the Armory, and I'm like, I really want to work with addiction. So that's probably how I got that. So I am like so excited. So excited. How I'm going to work the full-time job and do that full-time, I'm a little bit nervous, but
You are doing Project Renewal full time because there's
Yeah,
sometimes we've been able to.
We've been able to, yeah, I mean, we certainly, that's
Yeah.
very doable.
oh, I didn't even know.
That was
I didn't. The option was never presented.
we've got that.
Well, we have done it. We haven't advertised it to them. It's sort of on a case by case.
Well, now it's.
University has got also
Yeah.
other students, so
Whenever I talk to Pam Miller, she's always just like, no, school's your first thing. I don't care what else you have to do. Okay. I'm like, but I need to retain my job because my job is paying for school. I must keep my job.
No, I get
This is
it,
how this
you
is
know.
happening.
But listen, talk to Robin
Okay.
when you get there. I mean, we have done that
Even like
many times. And
things like I just got invited to a conference in Poland, and I don't know if I'm allowed to ask for a day off or move it. Like I'm so scared because now I'm in the student role. I'm like shy. I don't want to be that problem student that comes in with me. I wanted X, Y, and Z. So I tend to just not speak up. And I told Poland I don't think I can go. I'm like I don't think I could get a day off. We already, we had the interview. I put all my dates in. So I'm like, I don't even know what I can ask or what I can't ask, but maybe I just like talk to Robin, like, this is my situation. But otherwise, I'm just going to plow through with it the best I can. I'll get through somehow.
it's immersive.
I've made it thus far.
you have. You will.
I mean, at least being at the Armory, I can go to the office 2 days a week.
Yeah.
So if I need to appear, I can go at lunch or at night, in the evening, or come in early. That was a big thing to get in the Armory too. I gotta keep this job. 1 more year.
Yeah, I mean, I always thought that Fort was hardcore campus.
Yeah.
It is.
And I used to work in the Armory, different entrance, but first
Yeah.
6 years
Yeah,
I
she
worked
told me
there.
that.
And I worked in the Armory, so like it has a special place in my heart too. From just walking around that corner to go in every day. Anyway, I don't want to keep you guys. I'm just making sure everything is set up, and I'm gonna go in the back or stay for the talk. But I'm also on call, so if I disappear, it's because I got a text.
Can I use this?
Yeah,
'cause I've got-
it's muted
I've got
right.
this, so.
He's hooked up. This is muted right now. I'll mute it when you start. What is the? Oh, 9:24.
Yeah.
Do you need anything before you start? Fill up with water or anything? Bathroom? I can help you find it. Anything you need, let me know.
I'm okay.
Okay.
Thank you.
Glad I was here
And well
because IT
taken
never
care
came
of.
by. So that's why I came here. I'm like, I think I should, like, Jordana, put me with like someone who's not at Columbia already per se, so just in case they don't show up. So, so you got this, yeah. This we'll unmute you when you start.
Hello. I'm so happy for you with
Thank you.
your new chapter.
Yeah. No, it's taken sort of some figuring, but very, very happy with it.
Yeah. Yeah.
I like that change. See what commences. I've been working on that. I don't know if I ever told you that I created with a couple of other people, dream home assessment.
Oh,
It's
wonderful.
an executive function assessment that really appeals to people with mental health issues as well as a history of homelessness. So, because so many of the executive function assessments, they get shut down. This is either an individual or a group experience, and there's sort of a preparation and a visualization before you begin the assessment. And people have gotten quite excited about it.
It sounds really, really wonderful. Can we use it?
Yes, well, we did. I'm working with another faculty member who's a statistics buff, and we did some serious internal validity and reliability. Said it's not really good results. So, Chris
Gregory, yeah, she's with PSTP.
participated with me. She said she was actually going to use it with a few of the clients, but I'll send it to Rob.
No, I think it's wonderful because I think that the transition piece is such a huge
I'd love to turn it into an intervention group.
Yes. Yes. Yes,
Okay.
absolutely. Absolutely. My job has sort of changed there. I'm doing less training and more consulting, and I'll be talking a little bit about that. But yes, absolutely. I mean, I've been talking with our director of psychiatry around really beefing up OT across the board. I mean, the agency's been committed to this, and as you know, with the board, when they got on board with that, they loved that presentation. And, you were critical to that too. So, yeah. So, I mean, right now we've got 3 full-time OTs, a part-time OT, and we're bringing on another part-time OT.
So you hired Kara.
We hired Margot, Kara, Lee Westover, Patricia Modis, Jeff Goldberg. He's a friend of Danielle Blair's. So I mean, basically, we have 7 OTs in the agency, but there's really, we want more.
Margot is magic.
Margot. I don't want to lose her. She's like gold. She really is. She's the most solid of everybody. And it's hard to remember that she's only been out of school for a couple of years. She has the maturity and just the clinical reasoning. It's so...
Really, she could do OT in a hospital, rehab, she could have gone that way.
No, and we're so lucky to have her, and she's happy, I think.
Yes,
I mean,
no. She had done other things before coming
she
to
did.
school, and so I think she really did have a
She did. Yeah, it's all good.
Yes. Oh, and look, people are here.
Do you decide to start? Okay.
Hi.
Don't worry.
So should I start? Okay. What? I'm sorry. Okay. So. Okay. Good morning. Because they don't settle down. Hello. We're going to get started. Welcome to the second annual Columbia Commons Campus-Wide Day of Interprofessional Action, or IPE Day. It's an honor to introduce Doug Warren, with whom I've worked for more than 15 years within the field of community service and social justice. Douglas J. Warren, LCSW, is a clinical social worker and psychotherapist in private practice, a graduate of Syracuse University, higher and adult education, and New York University social work. He's presently the director for clinical training and program development with Project Renewal, a nonprofit social services agency dedicated to serving New York City's homeless. Prior to his current position, he was the director of addiction services and the program director for the agency's chemical dependence outpatient clinic. Mr. Warren has extensive clinical experience with addiction and dual diagnosis. He completed postgraduate training in psychoanalysis from the New Center for Advanced Studies in Psychotherapy, Cognitive Behavioral Therapy at the Beck Institute, and EMDR trauma treatment with the EMDR Institute. He has been an adjunct lecturer at Columbia University School of Social Work and trains master's level social work students. He provides clinical consultation throughout the metropolitan New York region. Mr. Warren has worked tirelessly and creatively with his Project Renewal staff to form deep partnerships with various CUIMC programs, including public health and occupational therapy. His influence is felt in many ways within the occupational therapy curriculum, including his annual lecture on substance use disorders, his support for our partnership with the Fort Washington Men's Shelter on 168th Street, his advocacy for OT fieldwork education sites at a variety of shelters and supported housing programs throughout the city. He helped to bring Columbia University social work student services to CHAMP. He has championed the formation of an OT department at Project Renewal, hiring Columbia graduates. As you will discover today, Doug Warren is both an extremely knowledgeable advocate for the homeless population, as well as an exemplar of interprofessional and participatory education.
Thank you. Good morning. Can you all hear me?
Actually, you end up muting both of those. So
Okay.
try that.
Try that. Can everybody hear me? Okay. So I'm very delighted to be here. And I'm going to be talking with you primarily about interdisciplinary approaches and how really essential they are to community-based services. And I would really like you to all think about making a career in community-based programming, because there's a lot of need for it, there's a lot of opportunity, and there's a lot of opportunity for creativity as well. So this morning, my lecture basically has two premises. One is that meaningful clinical care really is grounded in a clinician's and a program's commitment to social justice. And I'm thinking about social justice in the very broadest terms, not only in terms of equity and access, but I'm also talking about it in terms of quality of care. And the second premise that I have is that interdisciplinary collaboration really is a critical means for upholding that commitment to social justice. So a little background. Project Renewal has been around for about 52 years, and we are a social service organization that serves dually diagnosed homeless adults in the metropolitan region, and we serve well over 15,000 people every year. And we have a spectrum of services. There are basically 42 services that include all types of housing, shelter, permanent, and transitional, primary and dental care services, addiction and mental health treatment, and that would include psychiatry, post-incarceration services, vocational services, occupational therapy, and basic case management, which is thread through all of that. We have a very, very rich staffing, and as you see, our staffing includes everything from physicians, psychiatrists, to paraprofessionals. And this is actually critical when we talk about interdisciplinary work. And I'll be talking about why this is in just a little bit. So this is what we've got at Project Renewal. Now, I want to talk about why interdisciplinary work is so critical to serving communities that are underserved. And many of our clients, and I'm speaking primarily with Project Renewal, but I think this is true across the board in community-based organizations that I've consulted with, not only in the city, but in other parts of the country as well. And our clients actually bring to us a number of factors that really affect their clinical presentation. The first is poverty. Okay? Most of our clients come from very, very poor neighborhoods, backgrounds where poverty is rampant. And as a result of that, it feeds what I term as sort of a sense of chronic deprivation, which I'll be talking about a little bit later. Okay? Most of our clients also are overrepresented in terms of being African American and Latino. Most of our clients are actually men, although in our residential and primary care programs, gender is more 50-50. But we're also seeing increasing numbers of homeless LGBTQ clients. And in fact, in the last 2 years, we opened up the second shelter for LGBTQ adults in the city. All of our clients, and I can say this because we've done a prevalence study, have histories of childhood trauma. And that is not to be underestimated in terms of clinical presentation, because trauma does change how we think, it changes worldview, and it also leaves people with a foreshortened sense of future. There's a sense of helplessness and hopelessness that gets enacted when they present at our services. Sometimes it manifests in counter-conditioned behaviors like being aggressive. But underneath it, it is really childhood trauma that's been prolonged for a very, very long time. It goes beyond PTSD. It's really complex trauma that includes severe neglect oftentimes. And as I say, it really changes how people are able to receive services. And I'd refer you to the ACE study, which is actually one of the seminal studies that was done about 20 years ago. ACE stands for adverse childhood experiences, where the researchers followed a very large cohort of children into adulthood and saw the link between poverty, economic injustice, racial injustice, and then the onset of adult chronic disorders like asthma, COPD, diabetes, things like that, all of which we see at Project Renewal. Not only are our clients themselves traumatized, they often come from families where there's intergenerational trauma. And I would also include historic trauma in this. That there's been prolonged exposure to violence generation after generation. That also impacts early childhood learning about who people are, who's to be trusted, who is not, etc. And again, this does impact how they receive our services. One of the most powerful experiences that I had early in my career was an experience of working with a male client, African American, who one day was very upset about some of the limitations that the program was imposing. And he quite rightly said to me, says, you know, you want to help me, but your institution is oppressing me. Okay? And he was referring to the high thresholds that he needed to hurdle in order to be able to receive some services. He was referring to problems with Medicaid, Medicare, those types of issues, public assistance, because at that particular time there were thresholds that had to be met. And for whatever reason, he had trouble meeting them. And so the very institutions that purport to help were hindering. And I think we have to remember that if we're working in hospitals, we're working in community-based settings, that we need to be mindful that sometimes the institution can be perceived as an instrument of social control. And that presents a barrier for clients to receive services as well. Okay. Most of our clients also have prolonged experiences with criminal justice involvements. If you're homeless, you're likely to be arrested for all kinds of things. Open container, urinating in the streets, vagrancy. So the vast majority of our clients have some experience with criminal justice. This is not just true of social service agencies in the city. It's also true in hospitals. It's true across the board. And then there are language and cultural contexts that we need to be aware of. All of these things can potentially create barriers, perceived and real, that impact a client's ability to receive services. Now, all of this, for our clients, impacts their ability to, and their perception of our services and their ability to receive them. And I want to talk a little bit about the experience of chronic deprivation, because this is a psychological mindset that many of our clients are bringing in. If you are poor, if you are African American or Latino, or you don't speak the language, or you may have other barriers. Many of our clients come in with, again, this mindset. So they've experienced tremendous loss, okay, not only of material things, but psychological losses, emotional losses, relational losses as well. Okay? And so they come to us with many, many unmet needs. And in some way, when they come to us, that's a good thing, because they're hoping that we can indeed meet them. But sometimes their needs are so overwhelming, not only to them, but they can be overwhelming to us, because it seems like they're endless. And so they come with these unmet needs, hoping that we can meet them, but probably a little skeptical that we will be able to. And so we have to act in a way that's going to really try to meet them where they are, and I'll talk about that in a little bit too. One of the pieces of deprivation that I think is not to be underestimated with working in community-based settings is the the lack of safety that most of our clients experience in their lives. If you remember Psych 101, Abraham Maslow, you remember that the bottom of the pyramid is basic needs, food, clothing, and shelter. Those have to be present in order for anybody to receive anything else. But the next group of needs, which is where most of us are working in community-based settings, is the safety needs. And we must really work hard to create an atmosphere of safety, of acceptance, of respect, because without that, we're not going to get anywhere. And for our clients, particularly many of the poor clients that we've worked with, they've lost a sense of bodily integrity. If you've been in jail, you've been patted down, you've been strip searched. If you are living in a shelter, you don't have any privacy. Even if you're living in congregate settings, you may be living with a stranger. Okay, so there's a sense of lack of bodily integrity, of being able to control one's body. And for those of you who are physicians in training or nurses in training, this is a big issue because you're working up close and personal. Piece of practice wisdom: ask permission. Okay, can I touch you? I need to do this. Can I touch you? Because again, these are clients who don't feel a lot of personal control. So we need to be mindful of personal space and boundaries, because again, on the streets, those boundaries, that sense of personal space, is very different from what you and I experience. So personal control is another aspect of deprivation. These are people who generally feel helpless. Okay? They come to us with a lot of unmet needs, again, hoping that we can meet them, skeptical that we will be able to. And they may develop very, very unusual types of relationships with us. They may be sometimes very clingy. Sometimes they may be counter-dependent. They may push you away. This is all related to the mindset that they're bringing to us. And this is where this becomes a place where interdisciplinary work can become so critical. Because based on whatever training that you have, okay, you're going to be meeting some of those needs in very differential ways. One of the reasons that I am a great champion of occupational therapy is because occupational therapists are often teaching people skills that they don't otherwise have, or they've never learned. And so in our programs, occupational therapy is something that actually most of our clients are very hungry for, because they're learning something that gives them a sense of personal control, it gives them a sense of mastery, it mitigates the feelings of helplessness that they're living with, and it really helps them to develop a sense of relatedness that's very powerful. Okay? So obviously all of this means that their lives tend to be very unstable. Okay? If you're living on the streets, you're very disoriented in terms of time and also in terms of social norms. If you're living on the streets, or even in sometimes the shelters, the safest time to sleep is during the day. It's not at night. Prime time, if you're an addict, prime time copping time is between the hours of 11:30 and 3. Okay? So again, people's sleep-wake cycles are disrupted. Again, it's about being safe, but they're also not always clued into social norms, and that becomes a real challenge. Okay? So their focus, at least among our clients, is on survival. Okay? I'm going to do things that are going to help me survive. I'm going to avoid things that are going to make me experience pain. And my thinking is going to be very utilitarian. I'm going to do things that are going to help me survive, and that's it. Okay? And anything that's going to help me survive, including drugs and alcohol, because they will help me feel better, will be used. Okay? So these factors impact not only how, but when and why clients look for our services. Okay? But they also may limit their ability to accept and receive services. And those are three actually different things. Okay? And when we talk clinically, we have to really talk about each one of those in terms of how we're lowering barriers so that access can be created. But we have to assess, are they ready to accept the services that we have to offer? And then how are we going to provide them in such a way that they can receive them, that respects their ability to make decisions for themselves. Okay? So, as a result of all this, clients have very specific cognitive patterns that they're coming in with us. Okay? And again, this is where interdisciplinary work can be very effective. Okay? I'm not going to go through all of these things. I will say that you'll see this in hospital settings, you'll see this in community-based settings, that again, our clients are very mistrustful. They're going to be concerned for showing a tough image that may really belie a very deep fragility and even vulnerability. They may be very impulsive, and they often will split, and they're going to use emotional reasoning. Emotional reasoning is basically, if it feels good, it must be okay. If one is good, two is better. That's the core of addictive thinking also. Okay? And the implications for us is that they're going to have difficulty engaging with us. They're going to isolate us from each other sometimes. Sometimes their helplessness is masked by aggression. They have difficulty being vulnerable. They often fragment help, which again, another reason why we have to really develop systems of interdisciplinary discussion and collaboration. Okay? All of these things really do impact. Okay? Now I want to talk also about what the clients are presenting, because these also present challenges for us in terms of interdisciplinary work. So our clients at Project Renewal are addicted, they have mental illness, they have cognitive impairments, and I've separated that out from mental illness, and I'll tell you why in a minute. Many of our clients experience post-incarceration syndrome. There are medical issues, and there are functional challenges. Okay? And so I'm going to talk about each of these very briefly in turn. Okay? So addiction. Nationwide, even though this is now a 15-year-old statistic, the number's still pretty true. Okay? 84% of homeless men have addiction histories. 58% of homeless women have addiction histories, and one of the reasons that this is lower is that many homeless women are the primary caregivers for children, and they often cannot take care of their children or are at risk for losing custody if there is a known addiction problem. Okay? So that's one of the reasons that they're different. But we know that addiction among homeless people is 6 to 7 times higher than that of the general population. Okay? At Project Renewal, you're going to be surprised about some of this. Drugs of choice. Okay? So the primary drug of choice is either marijuana or alcohol. Okay? Even though there's an opioid epidemic, that the number of people who are actually abusing heroin, OxyContin, Percocet, things like that, has stayed relatively even among our population. 13% are using crack cocaine, and that's a change over the last 10 years. And the change is because of K2, okay, which is synthetic cannabinoid that was designed specifically for people who were on parole who wanted to experience the high without getting caught. The trouble is with K2, it makes people psychotic. Okay, that's what our experience is. I'm also including about almost 40% of our clients are using benzodiazepines. They're buying them on the streets. There are physicians who are rather lax with prescribing them. The clients, they know who they are, and they seek them out. So 3/4 of our clients are polysubstance users. So it's very rare to get somebody who's only using one substance. Okay? Now, why are people using substances? They want to feel better. That's across the board at Project Renewal. when I ask clients about what it does for them, almost invariably they say, I feel better. Better than what? Okay, that's a good question to always ask. So what are they medicating? They're medicating oftentimes psychiatric disorders. Okay, 35% of homeless people across the country have a chronic mental health condition. At Project Renewal, it's 85%, mainly because we have psychiatrically rich services, and other social services are referring people to us. Okay? 60% of people with chronic mental illness have are homeless at some point in their lives, and of course, it is what you would expect. It's depression, anxiety, schizophrenia, and the whole spectrum of disorders, trauma, including complex trauma. Okay. Cognitive impairments. I've separated this out because a number of years ago, I did a prevalence study at Project Renewal over a 7-year period because I was noticing that many of our clients are recidivists. They circle back into our services. And I thought, we're missing something, that this large number of people end up back in treatment, they end up back in the shelters. Something's not right, okay? And I was working in the addiction services at that particular time, and the recidivism rate in addiction is extremely high. It's 85%. And so there's something that we're clinically missing. And I decided to do a prevalence study around head trauma, okay? And what I found was shocking, okay? 80% of the people, and this is Wayne Gordon's study at Mount Sinai, but our statistics mirror this exactly, okay? 80% of our clients have experienced a traumatic brain injury. They've been hit in the head, they've fallen down, they've been experienced violence of some sort, okay? And the thing of it is that TBI often is not diagnosed, okay? It's untreated, and people, as a result of a TBI, have cognitive impairments that affect their coping, their ability to learn, and their functional skills. Okay? And so it affects their ability to adapt and to get better. Okay? So this certainly impacts their ability to receive services. Now, I did a deeper dive. Okay? So at Project Renewal, although 82%, that's about 14,000 people at Project Renewal have a TBI of some sort. Only half of those people they had lost consciousness. And of course, when you lose consciousness, the likelihood of clinically significant cognitive impairment goes way, way up. But this is the shocking thing. Only 7% were ever treated for it. So the vast majority of people seeking services, and I would assert that this is true in hospital settings, because Wayne Gordon did the study at Mount Sinai, okay, as well as community-based settings, are walking around with an undiagnosed brain injury that's affecting their ability to perceive, to think, to engage, and to receive the services that we have to offer. Okay? So, deeper dive. At Project Renewal, 63% of our clients have problems with expressing themselves with words. Okay? This is not about education. This is about literally coming up with the right words. Okay? More important, 62% have problems with auditory processing mechanisms. They're not understanding everything that we say. So, piece of practice wisdom. When you're working with clients, slow down. Okay? Because the mechanisms are not working very quickly. Those of you who are training to be doctors, when you are prescribing medications and you tell people how to take the medications, slow down. Repeat. Write it down. Have them write it down, because the mechanisms are not working. Okay? And we wonder why people don't take their medication. Okay? Medication regimens are complicated. Okay? This is very significant. Half of our clients have problems with attention. And again, no surprise to me that 2/3 of our clients have problems with memory. We need both language and attention in order to create memories as adults. If that is missing, of course they're going to have problems with memory. Okay? About half have problems with visual spatial skills, and half show problems with executive function. Emily did her doctoral dissertation at Project Renewal, and I was fortunate enough to be able to read it. And one of her findings was, and I think this is true across the board, that in community-based settings and in hospitals, in some ways, you as the institution and workers in an institution are actually providing executive function for clients who don't have it. Okay? And Emily's nodding here, so there's more to it than that. But I think part of our job is really to help people to organize. Okay? Because executive function is the ability to organize, plan, and follow through with tasks. Okay? And again, if people have TBI, they don't have this. They're at risk for not having it. Okay? Post-incarceration syndrome. Clients leaving prison are affected by their experiences in prison. Okay? And since most of our clients have some experience with jail or prison or being arrested, they're coming away from those experiences with a very particular mindset. And I do actually a half-a-day training just on this because I think it's so important. But people are leaving with institutionalized personality traits that has the core of learned helplessness at the center. Okay? They really rely on other people to make decisions for them. They become dependent on other people, on the institutions that we work for, because they're afraid of making decisions for themselves. They develop antisocial behaviors. Okay? And again, antisocial behaviors in this context are distinguished from antisocial personality disorder. Okay? And the theory here is that people develop these traits, the traits of aggression, counter-aggression, as a survival skill in order to survive a predatory environment. Okay? They develop PTSD symptoms, no surprise there, because again, you're living in a place where you're being threatened all the time. Okay? If you've been in solitary confinement, you are at risk for your brain literally changing because of social and sensory deprivations that occur. Okay? I wish I could say more about that because I find that very interesting. And again, you're going to reach for substances that are going to make you feel better. And yes, there are drugs in prison. Okay? And again, one of the things that I think our clients come away with is not having some of the more concrete resources that they need to transition back into community. Things like public assistance, Medicaid, basic things that we need to get along. Okay? And many people coming out of jail don't have any of that. Okay? So it's a very, very anxious, anxiety-producing situation. Medical issues. At Project Renewal, the major chronic medical problem is diabetes. Okay? People are not eating well, they're eating lots of carbohydrates. The incidence of diabetes is extremely high. And of course, with all of that, you have all the secondary medical problems that can emerge, including cognitive problems. Okay? Too much sugar, you're not going to think, your thinking is going to be very foggy. Okay? So malnutrition, diabetes. We have people with coronary issues, hypertension, hepatitis C, okay, among the IV drug-using clients. Respiratory illnesses such as asthma. Tuberculosis, not so much. Not anymore. Asthma's the big one. And then, of course, maldentition. Big issue. Okay? Functional issues among our clients. These are people who have difficulty with adult basic living skills, such as hygiene, grooming, basic nutrition, okay? Independent living skills. I cannot tell you the number of people who have ended up back in the shelter after having moved into their own apartment and not knowing how to manage money, how to put an apartment together. And even though they're very happy about being in their own place, they may not have social skills. They may not. They may seek out people that have been negative influences on them. I've had many clients who've been back within 3 months after having been in their apartment because they don't have the functional skills to survive. Okay, and this is again where we need to think beyond just mental psychotherapy, but occupational therapy is really critical here. Medication management. Taking pills, as I think you've gotten from me, is not easy. And many of our clients really need help with that because they have very complex medication regimens. They have problems with sensory motor integration. Okay? Those skills have been eroded over time. They're eroded certainly by addiction. They have difficulty with managing time. Funny story, it's very common among clients at Project Renewal to tell me that no, I cannot make my appointment with my therapist today because I have a doctor's appointment. And I'll say, what time is your doctor's appointment? It's at 3 o'clock in the afternoon. What time is your appointment with your therapist? 9:30. Okay? And they're not being resistant. There really is a problem with managing time. And again, this is where occupational therapy can be so critical, helping people reorient and to really manage time. Okay? Money management, huge issue. It's a huge issue for all of us, okay? But especially among homeless clients. If you've been living on the street, your primary mode is to survive. You're going to work for that. Your play skills, your hobbies, your leisure time does not exist. And people have to recapture that, okay? Homeless people, many of our clients have difficulty understanding that a goal may be a very big thing to be reaching for, but it has tasks, and we have to analyze the goal and break it down into tasks. That's partialization, and many of our clients don't know how to do that. They become overwhelmed, and they stop doing it because they don't want to fail. They have difficulties in sequencing. Okay? So all of these things really lead me to the importance of interdisciplinary collaboration. Okay? Our clients are very complex. It's very rare that we're going to be seeing a client who has just one problem. Okay? There's a multiplicity of problems, and in fact, most of our clients have some version of all of that. Okay? Therefore, we need a multidisciplinary approach. Okay? Each of the clinical disciplines, medicine, psychiatry, social work, occupational therapy, art therapy, substance abuse treatment, physical therapy, everybody has their own training. You have your theoretical orientations, you have research, and so you all have a very particular lens through which you are looking at a client. But I'm here to tell you that no one discipline has all the answers. Okay? No one, and in fact, it becomes very frustrating to think that you do. Okay? So we don't have a full understanding, and no one discipline has all the tools. Okay? We need each other. Okay? And so collaboration is really essential. Okay? So one of the things that I'm going to encourage you all to do is to go on the New York State Office of Professions website and become familiar with the scope of practice for each of the licensed clinical professions. Okay? Because you need to know what other people do. And just because you think you know what a social worker does not mean that that person is necessarily practicing within their scope of what they're licensed to do. How many of you know what occupational therapists do, other than those of you who are on occupational therapy training? Okay. Okay. It's critical. It's critical. Because OTs, those of you who are in medicine, OTs can save your life. Okay? OTs can save your life. Okay? Because they can help with medication management, in addition to a whole host of other things. So doctors-to-be, you need OTs. Okay? You need other people as well. Okay? As a person in private practice, okay, in addition to what I do at Project Renewal, I'm in private practice. Not only do I regularly refer people to psychiatry when medication is needed, I've also referred people to occupational therapy, okay, because sometimes they don't have skills. Okay? So again, just because you're in private practice does not mean you're not drawing upon other disciplines. Similarly, I've referred people to nursing, okay, for very specific things. So again, know what each of these does. It will help you do your job, and it will help you communicate better as well. So I'm not going to go through all of these. I do want to talk a little bit about paraprofessionals, okay, because you're going to be working with a lot of paraprofessionals, okay, and these are people who have very little training. They have minimal clinical training, and so one of the things that we often have to do is we have to educate them about what we do, okay. We often don't want to do that, but it can really be critical to helping. So I actually believe that all clinical people need to have some core competencies. And I think one of the things I'd encourage you to become familiar with is SAMHSA's recovery model. Okay? SAMHSA is a department within the Department of Health and Human Services. It's the Substance Abuse and Mental Health Services Administration. And they developed about 10 years ago this recovery model it's about seeing people as whole people with strengths. It talks about collaboration with them, joining with people's strengths. And I think it's very respectful, and I think it's a good thing. And all the clinical training that is represented in this room certainly needs to understand what this is and how it works. Okay? We also all need cultural competence. Just because a person looks or sounds like you does not mean that they have the same background. Okay? And I think it's really important not to make assumptions about the person who's in front of you. And I think one of the things that I continue to find very helpful is to be curious, to have an attitude of curiosity, and to hold your clinical knowledge and your training lightly. You never want to let it go, but you don't want to hold on to it so tightly that you're treating your theory instead of the person. Okay? And those of you who are psychologists know what I'm talking about. Okay? We always are treating people, and we need to be culturally competent. If you're not familiar, those of you who are training in psychiatry, become familiar with the DSM-5's Cultural Formulation Interview tool. It's actually in the DSM-5. It's very critical. I also think that it's important that everybody be trained in trauma and at least be informed about trauma-informed clinical principles, doing no harm, and really understanding trauma. Really critical. Okay? Trauma that's centered, that means that you're going to be focusing on the client, understanding that the client has strengths, and that in every time that you sit down with a client, you are responsible for creating safety. And this is a piece of practice wisdom I'd really like to emphasize. That even though you may be seeing somebody and you've seen this person for 3 months and you feel like you've got a good rapport, you need to always make sure that you're not assuming that the person is feeling safe. Things happen. Memories get triggered. And again, so our first order of business every time we see a patient is to make sure that they're feeling safe. In private practice, in my office, I have a couple of places where people can sit, and it's very interesting because one of the chairs, and I have a patient who sits in the chair that is farthest away from me that is possible to be, which tells me that there's a safety issue that I need to attend to. Okay? And one of the things that I have learned to pay attention to with him is that he will often come in and his jacket will be buttoned way up, but when it starts to come down, he's relaxing, the safety is there, and when he takes it off, I know that he's now okay. He's able to really do the work that he come here to do. Okay? So again, we're interested in creating safety. we're collaborating with the client. The client is an expert in his or her own life. And we do them a disservice when we forget that. We have expertise as well. We have to hold that lightly and honor the expertise of the client's life. Okay? I am a great believer in harm reduction in the broadest possible sense. Okay? There are clients that I work with who are not ready to stop using substances, so I talk with them about cleaning needles. I talk with them about hydration. I talk about them about eating. I talk about who they're using with. Are they safe? Are they at risk for being... So harm reduction in the broadest possible sense. Okay? And for whatever that means for your discipline, we have to look at it that way, because that's often where people start to accept the services that we have. Okay? Okay? We also need good engagement skills, and I do believe that core competence that everybody needs to learn is motivational interviewing. If you have an opportunity to train in motivational interviewing, take that class, because it will change how you interact with your patients. It even affect your personal relationships. I teach this. I had one woman who's taken my class 3 times, and she told me that it's actually helped her improve her marriage. Okay, so it really is a core competency. Okay, we all need to use our assessment skills, okay, that are germane to your clinical discipline. But I would also say that every time a client is in front of you, you need to assess how ready are they to receive what we have to offer. Okay? Just because they're in front of you does not mean that they're ready to take what you have to give. And we have to assess that. And actually, motivational interviewing teaches people how to assess readiness, because there are stages of readiness. Okay? And then we have to assess their ability to receive the services. What's the modality that's going to be best for them? Is it verbal? Is it written down? Is it practice? How are we going to best be able to serve them? Okay? And understanding that, of course, assessment is always ongoing. Okay? In terms of professional communication, obviously our training grounds us in terms of what we say to one another. We need to draw upon our knowledge, our experience, but we also need to draw upon research and a theory base. Okay? And we need, when we're talking to one another, to strive for a common language. Okay? Give you an example. Paraprofessionals will use the term anxiety or depression in a more popular sense. But if we're listening to that word as a clinician, those 2 words have very, very specific meanings. Okay? And we want to make sure that what we are understanding is what the person who's the paraprofessional is saying to us. Okay? Likewise, we may need to define terms not only for the patient, but for their collaterals, but also maybe somebody who's not as familiar with the jargon of your clinical discipline. Okay? So we really need to strive for a common language. In terms of interdisciplinary work, we need to be collaborative. As I say, no one discipline has all the answers. Okay? We need to talk and come at it with a mindset that what I have to offer you is going to be of benefit to you, and what you have to offer is going to be of benefit to me in terms of serving the client's best needs. Okay, so all of this supports wellness. Okay? And again, part of interdisciplinary collaboration involves really talking about how do we understand the client? How do we understand what the client's needs are? And this is not just with the client, this is with one another. Okay? How do we understand each other's training? Okay? So we need to be respectful of our interdisciplinary differences, but reach for a common ground. Okay? I also think that it's important that we be very mindful of power dynamics. Power dynamics really can impede the provision of services to the client, especially if you're in a power struggle with the client, or if you're in a power struggle with another clinician. Okay? So we need to be very mindful of that. I think that because project renewal is largely, even though we have many clinical professionals, the vast majority of our staff are actually paraprofessionals. And so communication with paraprofessionals really becomes a challenge. I need to educate them about what I do. I have to be mindful about how much information I'm sharing with them. I need to be discreet. I need to be clinically judicious. I don't need to give lots and lots of details. I need to give enough information so that they can do their job, but I don't want to violate the person's confidentiality. Okay? And that's where supervision really can be very useful. Okay? If you're not sure, to take it to a supervisor. I do think that it's important that you take some time to periodically educate paraprofessionals about what you do and what your scope of practice is, and again, being mindful of the power dynamics there. I think it's very important to be willing to listen to the experiences of non-professional staff, because oftentimes they have more exposure to the client than you do. And because they have more exposure to the client, how many of you have heard about the clinical phenomenon of the flight to health? I've been sick, I'm sick, I'm sick, they go to the doctor, I'm suddenly well. Okay, that's the flight to health. Well, many people, when they're seeing a clinical professional, put on a good mask. Okay? But they're likely to take it off with a paraprofessional, and the paraprofessional may be seeing things that you will never see. And that actually becomes really important. Okay? So when I'm running clinical consultation groups, okay, at my agency, I insist that people leave the letters after their name at the door, because everybody has something valuable to contribute. Even in one case, the maintenance guy. Okay? One of the maintenance guys was seeing behavior that no one else had seen because he was cleaning up after him, a client. And so it actually turned out to be important medical information that no one knew and prevented a major, major medical emergency. So again, we need to be willing to talk to people who are not within our training or within our clinical discipline, because they have insight and they have wisdom. So at Project Renewal, I take as many opportunities for interdisciplinary dialogue as I possibly can. We do this in team meetings, all staff, and again, you leave the letters of your name after you're at the door, because everybody has something to contribute. It's all valuable. Okay? Case conference meetings, where we're actually talking about cases, same thing. One of the things that I recently started at Project Renewal is we're doing monthly clinical grand rounds, where what I'm doing is that each of the clinical disciplines is represented. A case of a client is presented to whoever wants to come, and actually the attendance has been overwhelming. And so the case is presented, and each of the representatives, so I have a physician, I have a psychiatrist, I have a nurse, I have an occupational therapist, and a social worker, me. And everybody talks about how they're understanding what they're looking at, what they're hearing about, and if they were to be treating this client, this is what they would do. So it fosters a really very rich discussion, because we hear the clinical reasoning of the professionals in the room. But not only that, it really does change sometimes the flavor of how we're even approaching a client. I'm going to share with you a very brief story. A month ago, we had a client that was presented from one of our mental health residences. We had a very, very ambiguous psychiatric presentation. In many ways, she looked as if she was schizophrenic. Okay? But the interesting thing was that when we got all the people in the same room, every person who had interaction with her had a different experience of this person. So she was actually presenting herself differentially to every clinical professional. She would present one way to the psychiatrist, another way to her doctor, another way to the art therapist, another way to the case manager, etc. Okay? And as we were talking about this, I was really struck by this, that this is a client who has such everybody had a wildly different experience of her. And we would not have gotten to this. And one of the things that emerged from this is that we began to discuss whether or not her initial diagnosis was accurate. Because in her history, she had actually one of the most complex trauma histories that I've encountered, okay, that included not only physical and sexual trauma starting at 18 months, okay? So that means it's nonverbal, okay? She has the memories she has of it are really more sense memories. They're some a little bit of visual, but then she had experience of being sexually traumatized as a child, as a teenager, etc. Okay? So what we were looking at actually was somebody with complex trauma with psychotic features, okay, and structural dissociation. Okay, that was she's presenting differently for different people. Okay, so again, getting everybody together in the same room, we would not have come to that understanding had we not all had an opportunity to really come together and really talk about, from each discipline, what we were experiencing, what we were hearing. Okay? So again, really, really good opportunity. Incident review meetings where critical incidents occur, that's a good opportunity to talk about what did we miss, what happened, etc. But also, maybe we didn't miss anything. What can we do different next time? Okay? I also think that it's critical that if you were working, I'm going to use the example of trauma, that you really become part of a professional organization that has its focus on professional development and networking around trauma. Because, and I'm part of several trauma groups, and I'm in regular contact with psychologists, psychiatrists, other social workers, occupational therapists who are all treating trauma. So again, it's another opportunity for interdisciplinary dialogue and collaboration. Okay? And then, of course, if you're in an opportunity such as I to do program planning and development where I really am intentional about bringing people together to the table so we can talk about designing services that really help our clients achieve wellness and independence. Supervision. Everybody needs supervision. Okay? I've been doing this since the Jurassic Age, and I still pay for supervision. Okay? It's really, really critical. Okay? And even though you can be independent, supervision becomes an opportunity also for interdisciplinary dialogue. Okay? My clinical supervisor actually is a clinical psychologist who specializes in trauma. So we need to make a commitment as professionals. We need to commit to developing a practice that is informed by theory and research, okay? That is informed also by ongoing training and learning. You're never done. That's also informed by interdisciplinary dialogue. I cannot tell you, I feel very fortunate because my very first postgraduate job, my boss was an OT. That's really what got me set for the rest of my career in terms of this type of dialogue. Okay? And we need to practice in a way that is client-centered, respects client strengths, respects their readiness, right to self-determination, experiences that respects their experience and their wisdom and their insights. Because when we do this, it helps us to advocate at regulatory agencies, which you will all probably do at some point. It helps us to advocate for greater access to services. Okay? And it empowers the clients to participate in their own care. Okay? And so all of this can be very meaningful in the clinical setting to help the client have an experience of justice, okay? Because they're being seen, they're being respected as whole people, as people with strengths, as people who are collaborators, okay? So meaningful healing and wholeness is not possible when respect, safety, and justice are not present. Okay? And again, interdisciplinary care is really, in my view, critical to that end. And with that, I thank you for your attention. Questions? Thank you very much.
I'm so impressed to see you in the front row of a lecture early on time. Like, what? I showed up at 10 minutes late. Couldn't believe it.
Was that today?
I don't think so. I think I attended the little thing.
What is next one? I read somewhere that there is attendance.
Really?
Yeah. I don't know where.
When you mentioned that Project Renewal has opened a new LGBT-friendly shelter, both of us in Q had no idea actually what you were referring to, and so I wanted to come up and maybe ask you what the name of that place was. Marsh's house. Okay, oh, that's fantastic. Where is it located?
It's up in the Bronx.
Up in the Bronx.
It's actually here working.
Okay. Okay, perfect. I just wanted to hear about that because, yeah, that was not something that we were aware of. It's great to get it.
It's like, I think
Yeah, I feel like Science is the same way, mostly youth. So.
that's funny.
No, I've been listening.
Yeah. Well, that's fantastic to hear. Thank you so much for that information, and thank you for this presentation. It was wonderful. Sorry. Thank you so much.
Being very objective, not being
That's the Where did you go?
We're going to bump into, I mean, as you can say. It's surprising.
Yes, it is. Good. I hope that was helpful to them.
Oh, I think the way we made it very accessible. I mean, that they had to choose these things.
Good.
I'm going to head over to the department. Are you heading back to
I'm actually back downtown.
Okay.
Yeah.